The system recorded the denial. The clinical record said otherwise. Prior authorization. A process presented as a clinical safeguard for appropriate utilization of medical resources, has been subject to sustained examination by health policy researchers, federal auditors, and physician organizations since its widespread adoption in managed care. The system recorded the denial. The clinical record said otherwise. The accumulated evidence produces a consistent finding. What was framed as quality assurance functions, in practice, as a documentation screen optimized for payer outcomes. The language of medical necessity appears throughout the process. The clinical reasoning frequently does not. This examination reviews the documented mechanisms of prior authorization denial, the administrative burden it imposes on the clinical workforce, and the outcomes evidence connecting denial patterns to patient harm. The system left a record. The record is available. Chapter: Case background. Prior authorization entered widespread use through the 1980s and 1990s as managed care organizations sought mechanisms to reduce expenditure on high-cost procedures and specialty referrals. The initial framework was presented as an evidence-based quality measure, ensuring that prescribed treatments met insurer criteria before reimbursement would be approved. The framing was clinical. The function was financial. By 2023, the American Medical Association's annual survey documented that physicians and their staff completed an average of 43 prior authorization requests per physician per week. 46% of physicians reported that prior authorization had led to a serious adverse event for a patient in their care, including hospitalization, permanent disability, and death. The administrative infrastructure required to navigate the process has grown in parallel. A 2022 analysis published in Health Affairs estimated that physician practices spend an average of 14.5 hours per physician per week on prior authorization tasks. For a solo practitioner, this represents more than a full working day, not spent delivering clinical care, but generating documentation for insurer review criteria that are proprietary, unstandardized, and not subject to external audit. The burden is not distributed evenly. Specialists, orthopedic surgeons, rheumatologists, physiatrists, physical therapists carry disproportionate volume. In musculoskeletal medicine, specifically, prior authorization requirements for imaging, physical therapy, and surgical consultation represent among the highest authorization burden of any clinical specialty. The time spent is not discretionary. Chapter: Initial findings. The first submission denial rate warrants examination independent of its volume. CMS data from 2022 found that Medicare Advantage plans denied 13.6% of prior authorization requests at first submission. Upon appeal, 82% of those denials were overturned. The clinical basis for the denial did not change. The documentation changed. What this pattern reveals is not a system identifying inappropriate utilization. It reveals a system that responds to documentation format. The same diagnosis, the same patient, the same treatment plan, resubmitted with modified framing, moves from denial to approval. The clinical presentation is constant. The language surrounding it is the variable. This variability is systematic. Insurers issue internal coverage determination criteria specifying what documentation elements and what language patterns trigger approval. These documents are proprietary. Physicians who have accessed them through litigation and regulatory inquiry describe a consistent gap. The clinical language taught in medical training is not the administrative language required for authorization approval. They are distinct dialects of the same nominal purpose. The finding, repeated across specialties and across payer types, is not that the treatments were inappropriate. The finding is that the documentation was written in the wrong register. Chapter: Forensic Investigation. A 2023 report from the Department of Health and Human Services Office of Inspector General analyzed prior authorization practices across Medicare Advantage organizations. Federal auditors found that 13% of denied services met Medicare coverage criteria. meaning the denials were not clinically justified under the plan's own stated rules. For inpatient admissions, the denial overturn rate on appeal reached 75%. The OIG noted that review processes varied significantly across organizations and that some denials were based on administrative technicalities rather than clinical assessment. The epidemiological record on harm is not confined to federal audit data. A 2019 JAMA study found that cancer patients whose prior authorization for chemotherapy was delayed by more than 14 days had measurably worse outcomes at 12 months. In rheumatology, step therapy requirements, mandating that patients try cheaper alternatives before accessing prescribed medications, were associated with increased rates of joint damage in multiple longitudinal studies. The step therapy drugs were not ineffective. The delay was the variable. In musculoskeletal medicine, prior authorization denial for physical therapy and surgical consultation correlates with documented increases in opioid prescribing, emergency department utilization, and surgical complexity at the time eventual approval is granted. The step therapy drugs were not ineffective. The delay was the variable. The arithmetic is consistent. Delayed authorization for conservative management increases the eventual cost of care. The intermediate cost to the payer is reduced. The downstream cost is externalized. The timeline in prior authorization cases is constructed through denial logs, appeal records, and clinical notes. Standard insurer contracts define turnaround as 72 hours for non-urgent requests and 24 hours for urgent. AMA survey data from 2022 found that 93% of physicians reported delays beyond these contractual windows. 35% reported that a patient had abandoned recommended treatment due to prior authorization burden. The timeline is documented in the medical record. The outcome follows the delay. Expert assessment of prior authorization, drawn from health policy literature, federal testimony, and specialty society position statements, converges on a single characterization. The process as implemented does not function as a clinical review. It functions as a documentation proficiency test. Requests written in the language the system recognizes, with the correct diagnostic specificity, the correct step therapy notation, the correct medical necessity framing mapped to plan criteria, move through the system. Requests written in standard clinical language move slowly or do not move. The clinical judgment is the same. The documentation format is not. Chapter: Resolution. The accumulated evidence resolves to a straightforward finding. Prior authorization, as currently implemented, operates as a language barrier between clinical judgment and treatment delivery. The barrier is not impenetrable. It is learnable. Physicians who understand how to write a prior authorization letter in the format reviewing organizations recognize, who know how to map a clinical presentation to the specific criteria language that triggers approval, how to anticipate denial rationale and preempt it, how to frame medical necessity in the register the system responds to, achieve significantly higher first-pass approval rates. Prior authorization, as currently implemented, operates as a language barrier between clinical judgment and treatment delivery. The barrier is not impenetrable. It is learnable. Their patients are not clinically different. Their documentation is. This is the gap that AI documentation tools address directly. The language of prior authorization approval is pattern recognizable. The criteria are finite. The framing, once understood, is reproducible across cases. For physicians managing musculoskeletal conditions, where prior auth volume for physical therapy, imaging, orthopedic consultation, and surgical procedures is among the highest of any specialty, a structured set of prompts calibrated to that language cuts approval time, reduces administrative burden, and reduces the frequency of first submission denials that would otherwise require appeal. This is the gap that AI documentation tools address directly. The language of prior authorization approval is pattern recognizable. The criteria are finite. The framing, once understood, is reproducible across cases. The documentation tools referenced in this episode are linked in the description. They were built for this problem. The prior authorization record is long enough. The file remains open.